Thanks, Ashok. And thank you, Stella, for inviting me onto the panel today. My pulse rate hasn't quite settled after listening to those testimonies. And as ever, when I hear such stories, I'm at once deeply humbled, but also it's a very grounding experience for a clinician to hear that. As Ashok says, I'm involved quite a lot with teaching at undergraduate and postgraduate level. And one of the questions I sometimes posit to, trainee obstetricians and junior midwives, as well as medical students, is, what do you understand about childbirth trauma? Because what our two witnesses have just discussed is really traumatic birth experience. Now, almost without fail, when I put that question to that particular group, I get hands go up in the air and I get answers about, traumatic childbirth is, that code red cesarean section, the cord prolapse, the shoulder dystocia. And whilst that those are events that could be very traumatic for women, what our two witnesses have spoke to is the landscape of maternity, where in reality, that landscape is peppered with stories that you've just heard, like you've just heard. So that they've not been asked about what matters to you, not being asked about how you feel about particular interventions, not being heard, dehumanized, this notion that you feel you're a number on an assembly line rather than a person with full entitlement, denied rights over your body, rights that outside that delivery room door, you have, full access to, denied agency because the man-made world of obstetrics privileges specialized knowledge over the woman or birthing person's thoughts and feelings. Now, one of the interests I have, which partly stems from work I do in the Rose Clinic, the clinic around women and girls FGM, is trauma. And that has led to my own personal wider exploration of trauma in childbirth. And I was speaking to a psychologist not so long ago about the PTSD arising from childbirth trauma. And, our second speaker alluded to her trauma after the birth that still lives with her. And when we think about PTSD, it tends to be caused by peaks of emotion during an adverse experience. In this context, we've been talking about birth experiences. And those peaks of emotion lead to those memories of the event being coded into part of the brain, which is different from where we normally store memories, such that triggering thoughts or events or further pregnancy can lead to recurrence of PTSD or ongoing PTSD. Now, in trauma therapy, the two peaks of emotion that tend to be addressed is one is a peak of emotion around that fear that you yourself could die or your baby could die. Now, in terms of psychological therapy, provided that neither has died, that those peaks are actually easily reduced. The second peak of emotion that leads to that encoding in the wrong part of the brain is that feeling of being alone, not being listened to, that nobody actually cares, that you're just a number, that you're a thing, an object, dehumanized. Now, those peaks in trauma therapy are much harder to deal with, often because they tap into society's sort of impact on a woman or the person's long-standing feeling that they're not good enough, that they don't matter enough. So the ask here is simple, isn't it? Women and birthing people want to be treated with respect. They want to be involved in the decision-making about their bodies and their pregnancies. And it is such a simple ask. It is mind-staggeringly simple when one considers the huge progress and strides that have been made in women and gender rights over past decades. So why are we even having such a meeting today? Why is it so difficult to meet this ask for each and every person giving birth in a consistent manner? Because there's no doubt we get it right sometimes, and we get it right quite often, but we don't get it right universally. Now, I think part of the challenge when we think about shared decision-making is that there's confusion about what it actually means. And part of that confusion is the conflation between shared decision-making and informed consent. That if we think about informed consent, that means we have to go through every risk and every benefit, because we've all heard about Montgomery. which, by the way, has been largely misunderstood by many health professionals in the front line. But we think because that we have to go through every single risk and benefit, that that's going to take too much time, and that the workflow in our busy delivery suite would just simply grind to a halt. And embedded in that is the notion that shared decision-making, because it is informed consent, only refers to big decisions. Now, those two misconceptions overlook important facts. Shared decision-making is not equal to informed consent. Shared decision-making is a continuous process. It is a conversation. It is not simply about listing risks and benefits. Like any conversation outside a delivery room, it involves listening and talking, reflecting, listening, talking, pausing to listen. And shared decision-making is a continuous process, not just about the big decisions on delivery suite, such as our second speaker talked about, the going to theatre, forceps versus cesarean section. Those are important decisions. But many clinicians in the front line think that shared decision-making only really is involved in those type of decisions, mode of birth. But if anyone, and I'm quite certain if I were to look at the list of participants and take a poll about who here has given birth, you would surely say that in the course of normal birth, normal labor, there are many decisions that are made. Our first speaker talked to the decision around continuous monitoring, break-in of waters, vaginal examinations, oxytocin augmentation of labor. Many, many decisions get made every hour of every labor. And the shared decision-making is part of that. It doesn't take time, it's a conversation. It's listening to what matters to that person in front of you, to their concerns, and addressing that before we dare to move on. Now, this culture shift towards universal shared decision-making in maternity care demands a willingness to change and to recognize that each and every birthing person is a fully entitled citizen. And I know that Stella's going to pick up on some of that shortly. Now, the other concern that many health professionals have is that women are non-experts, and can they really be trusted to make a decision, particularly in a time-critical situation? Now, that is a Pandora's box of implicit bias, because what we're then talking about is, do we truly believe that a woman or birthing person in labor has rational capacity to make that decision or to participate in that decision-making process? Again, I'm hoping that Stella picks some of this to explore the origin of some of those implicit bias that many health professionals have working maternity. But over and beyond that, I think it's worth reassuring any maternity professional listening to this that in my experience, and I've been working as an obstetrician for over 20 years, that it is very rare that in a time-critical situation that women and birthing people don't want us to help them navigate that decision-making process and to safely deliver their baby. But the thing that they're asking is that at least we pause to communicate where we are at that point. Now, in shifting the dial towards true shared decision-making, as health professionals, we also need to rethink about how we talk to women and birthing people about risk. And I know that Sue's going to talk about that shortly. But in brief, as a health professional, we seek to practice in an evidence-based manner and to avoid harm. However, as health professionals, I think we've a tendency to overstate risks and to couch risk in terms of relative risk, rather than actually think more deeply about the absolute risk of harm. And more importantly, what the woman and the birthing person in front of us, what their patient-specific risk of harm might be if we opt for intervention A over B or whatever. And above all, there was something that the second witness said, which just made me have palpitations all over again. It's this ethically challenging playing of the dead baby card. Do this or else. And I think that is an extreme form of coercion, which we should seek to avoid. Now, I'm mindful that you've got two brilliant speakers coming after me. I'm going to wrap up. And I want to just finish on a very simple point, that as we consider shared decision-making in the delivery suite, in our labor and births, we should remember that shared decision-making isn't just for people who look and speak like us. it should be universal. And we must not exclude those who look different, who sound different, who come from different cultures, who identify as a gender that is perhaps outside our own everyday experience. But the bottom line in all of this is that women and birthing people are talking. How radical it would be for us to actually listen. Thank you very much for your attention.